Hi, everybody. I'm Mark Plaster,
And I'm JD Landon.
and this is EP Talk, a place where EPs, emergency physicians, aka ER docs, come talk about things that are important to us. Sometimes it's political, sometimes it's professional, and sometimes it's a little bit of both. So today we're going to be talking about ultrasound. Actually, as you can see, I'm recording from it's summertime, and it's the boat. I'm aboard the boat, the Dawn Treader. I wish all of you guys were out sailing with me, but maybe sometime we'll get to do that. And JD is probably getting ready to go to work, and I do feel sorry for you, but not that much.
Somebody's got to do it.
That's right. Somebody's got to make the money. And JD's just finished his ultrasound fellowship, and he's going to share some things with us. But before we jump into the actual technique of ultrasound and some things that are happening with that, I wanted to talk a little bit more about, we started this conversation in a previous podcast about the broad-based ultrasound acceptance. Okay. JD, how big is your class of emergency medicine residents?
So we've got 10 per class, like the kind of middle to slightly low. I think the average nationally is probably 11 or 12.
11 or 12. Okay. And out of that, 2 of you went on to do ultrasound fellowships, right?
Correct. In my year, it's been 2.
Yeah, in 2. Okay. And as a result of that, I think you told me before that as a result of that year-long fellowship, you basically are capable of doing anything an ultrasound tech is able to do. And as far as all the various procedures that we call an ultrasound to do, okay, that's not the case with the majority of emergency physicians. I learned to do a few OBs and transabdominals. Certainly I learned how to do the FAST exam. And certainly the cardiac evaluation, at least to some degree. And yet I think that as I traveled around the country doing locums work over the last 25 years, I found ultrasound machines basically gathering dust. And for a lot of different reasons, the average community emergency physician, I don't think feels comfortable doing that. And my question here is, because you and I have kind of come to the conclusion that it's an essential skill, or it could be an essential skill. And in fact, that you were saying that when you went through medical school, that a lot of things were taught using ultrasound, and that students were ultrasounding, from almost day one. And so it's a skill that's being brought a little bit more broad based than it was. I don't think anybody other than maybe OB does ultrasound as a part of their practice, but emergency medicine, it seems to me like needs to be an essential skill of every emergency physician. Why not? Why is it not? And that's what I want to explore.
Yeah, I mean, obviously I agree. I do think it's an essential skill. I do think that, 10 years from now, there's even an argument that said, why even do an ultrasound fellowship now? Because so many of these new grads coming out of medical school have pretty significant training from medical school. Mm-hmm. And then you add on top of that a residency program that's focusing on the ultrasound. And I think most all emergency medicine residency programs have requirements, graduation requirements. Got to do a certain number of aorta scans, a certain number of GU scans to graduate. And so I think that we're going to see in the next 15 years, probably a shift where the majority of physicians are comfortable doing their own bedside echo, comfortable doing their own FAST exams for sure. And I think that slowly, probably over the next 15 years or so, it's going to probably branch out even to more. The people are getting more excited about nerve blocks, which I know we're going to talk about at some point. And so it's definitely a tool. I think that it allows us to make faster, quicker decisions at the bedside. But it's definitely one of those skills that takes time.
It's a hand skill, isn't it? It's an operator dependent hand skill oftentimes. I mean, because I know because I've publishing Emergency Physicians Monthly, we've had several really qualified ultrasonographers, EP ultrasonographers who have been on our editorial contributors for years. And they come through and tell all these great stories about this stuff. And then I go into my shift that night and they go, let me see if I can do that. And I just can't seem to get the same things, the kinds of pictures that they're putting out. And after a while, I get discouraged and, I let it go. So it's definitely it is a and it's a hand skill. It's a motor skill. You got to see what you're doing. You got to know exactly where to put the probe. You got to know all the various ins and outs of penetration. I'm kind of even blowing smoke right now because I'm not even sure exactly what it is. And my question here is going a little bit further. Would it not come a time when, to be a board certified emergency physician, you must be able to do certain kinds of, must be able to perform that skill?
Well, I mean, they're already showing that as a board we care, right? And so there's quite a bit of ultrasound that you were required to interpret on my written boards just a year ago. And so they're clearly starting to add to that. The other thing that I think, ACEP is doing is they recently started this program, the FPD program that we can sit for every other year, focus practice designation, which is sort of emergency physician's way to say, okay, this is what we think the level or the standard is for a board certified emergency physician who is a specialist in ultrasound. And so you look through what they're covering on that test, and it's every part of the body. I mean, it's a pretty in-depth, thorough exam. I'll be taking it next year. And I mean, to me, that's a signal that ACEP is saying that they see this as a core content, core skill set.
Yeah. Well, that's actually very, very encouraging. It's a little intimidating for an old guy who doesn't know that.
It's definitely intimidating.
I'm gonna have to learn how to do a what, and I haven't done that before. But the truth is that, and I think that one of the things we're going to try to do with you, pick your brain. I'm going to pick your brain about ultrasound, and I learned to do transabdominal. In 1982. I learned to do a highly pixelated transabdominal ultrasound, pelvic ultrasound, be able to tell, whether we had an ectopic or a live fetus, that sort of thing. And it wasn't until actually after I graduated that they did transvaginals, so that was a new skill that I had to learn how to do, was to do transvaginal. And then obviously the FAST exam was around the same time, and we all learned how to look for, traumatic bleeding in the gutters and stuff like that, and then some heart. Can you tell whether you've got a heart motion? Whether you can tell you've got a campanade, cardiac effusion, that kind of thing. That's kind of it. Okay, that's where this old dog kind of finishes up. Tell me some other things. Let's walk through them. About, you said head to toe, covered every part of the body.
That's a lot.
I know, but tell me, just give me kind of a smorgasbord, not a 30,000 view. I want you to start listing off the areas that you can, and the skill set you can do with a qualified ultrasound.
So I mean, literally, we can start head to toe. I mean, I do ocular exams pretty regularly, where we ultrasound the eye, looking for retinal detachments, lens displacement, foreign body. I mean, vitreous detachment, vitreous hemorrhage, all sorts of different things in the eye. And that's a really fun, quick, easy exam to do that you could literally, I mean, I could teach you in 15 minutes. And it's such an easy space to ultrasound. You're basically ultrasounding through, a 0.5 millimeter lid, eyes closed, gel on top of the eye.
Okay, you put this. Some guys have put water into a glove and back the probe off of the eye. Is there a reason for that, or do you go directly onto the lid?
So, I mean, there's probably 4 different reasonable ways to go about it. When I actually first learned as a med student about doing eye ultrasound or ocular ultrasound, we were using Tegaderm, and we'd actually close the eye, put a Tegaderm kind of, and put it in so there wasn't any air there, and cover it, and then just do whatever gel, right? Because you're kind of protecting the eye.
Yeah.
What I do now is basically use sterile gel and a sterile probe cover and just go directly onto the eyelid, and it's fast, it's easy, it's quick.
So the only reason to ever use a glove was actually just to keep gel out of somebody's eye?
I've never tried it, that approach. I think that you would just need to make sure that you have enough contact between the water in the glove and the eye so that there's no air between that interface.
Gotcha. Okay.
Ultrasound doesn't particularly penetrate air very well. And so as long as you didn't have air, it would work fine. And in some ways it might be easier, right? because you could hold the ultrasound probe a little bit further away from the face if you have a full glove. But
Yeah.
yeah, so many different ways to do that. Moving down nasal fractures. There's a couple studies looking at diagnosing maxillary sinusitis.
Really?
PTAs, people are doing intraoral and extraoral PTA ultrasounds.
PTA.
And the peritonsillar abscess.
Where's the ultrasound? Peritonsillar abscess, you can see. You can open up their mouth and see it.
Exactly. So I don't do them very often. I probably shouldn't be saying that.
Okay.
But there are some people who actually use it for, again, I think this is personally a bit crazy, but they'll actually can use the curvilineal probe kind of submandibular, kind of shoot through and see the back of the peritonsillar abscess, and you can also visualize the big red.
Yeah.
And you can actually use it and do dynamic guidance. So your ultrasound's here and your needle's coming in here.
Okay.
So I think that that's like some pretty super duper fancy video gamer stuff. You just have to really 3D flip everything in your head to be tracking a needle coming at the probe. I don't know. Anyway,
I got you, but that's a lot of people's actual nightmare is incising a peritonsillar abscess and in the process incising the carotid.
I think going after a PTA just because it's obvious and it's huge and you can see it is perfectly reasonable to do, and you use your landmarks, and the likelihood you're going to hit big red is super low if you use your landmarks, have the correct angle, and so
don't go for the spine when you're once you get in, you got possibly call it a win.
That's right.
Okay.
And there's all sorts of cool tricks with that procedure to make sure you're not going too deep. And one of the things actually ultrasound is helpful for is if you were to use what we call an endocavitary probe, which we otherwise know as our transvaginal probe, right? It's just a probe that goes into spaces, right? And so, you put a sterile sleeve or cover on that, and you can go in actually and look and tell yourself exactly how deep it is to the beginning of that abscess. Then you can take that information and then actually put a mark or a measurement, or use the old cap trick to so that your needle basically stops at the depth you want, and you know exactly how deep. So there are all sorts of kind of cool, helpful adjuncts that you can use it for. Then coming down, you've got the neck, obviously thyroid masses. Somebody comes in, you're thinking maybe thyroid storm, who knows? You could throw the ultrasound in there. If you've got a big, hyperechoic thing that's all hyperemic and super angry looking, you probably have got hyperthyroidism. A lot of people are using it now either intra or post intubation to check to make sure that your tube is not in the esophagus.
Good.
Also super easy. Like you could teach somebody in 5 minutes how to look for that. People are using it if they think it's going to be a super scary airway to literally mark the cricothyroid membrane. Super easy to see with ultrasound, particularly in somebody who's got, a couple centimeters of issue there.
Yeah, exactly.
You might get yourself...
That's a nightmare. I mean, honestly, that's a nightmare, trying to find... I know people who were otherwise qualified who couldn't find it because of obesity. Yeah. I mean, that'd be a next layer.
PBLs... one of the classic things, right, is our classic, you think our chest pain plus, right, thinking about aortic dissection. Let's say you're seeing somebody who's got chest pain and some weird, unusual, neurologic changes. You throw the ultrasound here and look at the ICA and look to see if you got a dissection flap going up into the ICA. Obviously, right, these aren't rule out things, but if you've got a suspicion, it takes 2 seconds to put the ultrasound on there, and if you've got a flap, you're done. You just saved potentially 2 hours of workup. And that immediately, right, if you see a flap up here, you immediately know it's type A. So you're done. You're calling surgery, you're calling vascular, and you're moving forward.
Yeah.
Coming down, obviously lungs, clavicle.
We talked about lungs the other day, but in case somebody didn't hear that podcast, I want you to go back over some of the lung applications, because I found those particularly interesting.
Yeah, no, I think lung ultrasound has in some ways, because of COVID, has taken a jump into the spotlight, right? I mean, so there are some really cool early ultrasound findings in COVID that were pretty sensitive and specific. And so I think everybody, Dr. Lichtenstein is probably the OG of lung ultrasound. He created a bunch of the initial early protocols. But we're looking obviously for pneumothorax is the classic, but then also pneumonia for
Yeah.
looking for consolidations, looking for pulmonary edema, obviously effusions.
Now, you were telling me the other day that whereas in a lung consolidation, a radiograph, we're looking for fluid in the lung, which creates, of course, a white shadow. And prior to that, oftentimes you'll see hyperemia when there's inflammation, but there isn't quite consolidation, which is what the radiograph finds. And so
Yeah,
the
and so
ultrasound can be a preliminary show when things are not going to cause people, you hear them, and the traditional method of seeing whether they've got a lung consolidation doesn't really tell you that in actual fact that whole lobe is inflamed and
yeah,
it's
and
hyper.
I think the hyperemia is not necessarily a super early finding, but I think it's one of the findings. The other ones that we look for are what we call air bronchograms, right? So if you've got these areas and the walls are inflamed, you can actually see these areas of air with, pus and obviously,
Right.
collapsed tissue. And that becomes apparent, right? Because it should be all air. And
Yeah.
if we see concentrated areas of tissue, well, then, there's some,
Right.
theoretically, right, could also be atelectasis. But in the right setting, it's a slam dunk pneumonia. Whereas, the chest X-ray is not going to be super sensitive.
Yeah.
When it comes to MSK, I do a lot of shoulders. I do a lot of knees.
Oh, okay. When you say shoulders, okay, most they like, for instance, bursitis, calcific bursitis, and things that don't. You can find point tenderness. You say, okay, well, I think this is a bursitis. I think you've got inflammation there, but you can actually show it with ultrasound.
Yeah, and I think it's one of those things where it's funny. I swear I probably do more ultrasound in our focus care kind of fast track area than I do in the acute treatment area because I can just sort of leave it in the room or leave it just outside the room. And, you have a patient come in with shoulder pain they've had for weeks and weeks, and it's a pretty low risk story for all of our other sort of less usual, pneumonia or chest pain and from ACS or something. You grab the ultrasound and you show them, the 5 or 6 different tendons in their shoulder, and you have them watch it move across the screen. You show them the areas where there's a little bit of edema and fluid collection. You show them the cartilage signs. Say, yeah, these are all signs you've got tendonitis,
Yeah.
and you need to go to an orthopedic surgeon, and there's nothing else we're going to do today.
Yeah.
And it takes 10 minutes. You finish your conversation, you discharge them. No X-ray, no lab work, none of that stuff. And they're like thrilled. They're like, this
Right.
doctor did more for me. The last guy just did an X-ray, but you did an ultrasound.
Or they feel well. The other, I'll be honest with you. The thing that I think most people are feeling is that, well, you got tendonitis. Well, how do you
Right.
know it's tendonitis? What are you looking at? You know, well, what is that? Just some sort of a garbage, garbage diagnosis? Oh, you got tendonitis. I mean,
Yeah.
really,
I mean, really, we're diagnosing that on physical exam, right?
right?
And
I know,
you can, and that's how we do diagnose it.
right. But I'm just simply saying that a lot of people or a lot of smart people are looking at it and going, "Doctor, what are you really basing that on? The
Sure.
fact that you can't see anything else and it's not broken?" You know, and whereas you have really distinguished yourself as a clinician working on fact. If you say there's the tendonitis, you can see it,
Right.
and if you want, I can put a a steroid shot into that space, and we'll see if that seems to help you, or I can send you to an orthopedic surgeon and they'll do it, or whatnot. But that is your problem. I mean, how many times do people they want to believe us? Okay, yes, you have X, but then you might get an X-ray so I can see it, or somebody can see it, and I think that really does patients a lot of good. I mean, so
I always think about my son. We took him to urgent care. He had like a little croupy cough, and I was at work, and we thought he might be having a little respiratory distress, and it's like a $530 bill for a 20-minute visit.
right,
And so I always think to myself, when this person gets this bill,
yeah,
are they going to think back and be like, you know what, that was probably worth it? Like,
yeah,
it
you
wasn't a
should,
lot. I wasn't dying, but was it worth it? And I feel like the ultrasound, it's a relatively cheap and it's relatively quick. But I definitely feel like patients feel like they were more cared for.
yeah.
And there's something
I think they are.
powerful.
I think they
Yeah,
are.
I think there's something powerful too that they get to see their body. It's amazing, you're doing a heart or a gallbladder, and I always try to make sure I flip the screen a little bit so that they can watch too and just do,
Yeah.
quick, this is that. And I think patients are just always fascinated, right? Because otherwise, CT scan, right, we're getting a lot more definition and detail. But like, and I'll sometimes go through the CT scan, but they can't see it happening in real
Right.
time.
Right.
But to them, see their own, beat, heart beating, it's like,
Yeah.
it's cool and they love it. They always love watching.
Go on. We're
Okay.
running out of time here quick, but
So yeah, so shoulders I do and knees are probably my prime. I mean, there's guys that have made MSK like their
right.
baby and just can do amazing stuff. But that's for me personally, that's what I do. Definitely lots and lots of heart, aorta, and then going down into the abdomen. Obviously abdomen or aorta in the abdomen. We're doing kidneys. We're doing bladder.
What are you looking for in the kidney?
So I think our primary, the probably big three for me is hydronephrosis, right? So every kidney stone, I'm usually checking for hydronephrosis. If they're a chronic, kidney stone, same pain, doc, exact same pain, and I look, their kidney function's fine. They don't have a UTI, and they've got no hydro. I'm sending them home with pain
Yep.
medications and Flomax and having them follow urology. No CT scan, like nothing, no big workup. It's if you can get, even if you can get an iStat and just see their creatinine and a UA real quick, that could be a 20-minute visit if it's their chronic kidney stone and you're not concerned about something else going on. Other things for kidneys, you can, and sometimes I will do this, look for venous and arterial flow. And there's this whole resistivity index that you can look at. I don't do it often, but in certain cases I might consider doing that. And then the other thing that we're doing, same thing, looking at the blood, is the VEXIS scan, which at some point maybe we'll talk about. The VEXIS scan is a little bit in the weeds. It's a little bit a new scan, probably more applicable to the ICU, but it's basically a combination of ultrasound findings, one of which is the kidney, to look for signs of fluid overload and venous congestion. So those are my big three. Obviously, you can look for masses as well if somebody's got flank pain and peeing blood, and you can potentially get a quick tip on renal carcinoma.
Yeah.
We've also got obviously all sorts of liver and gallbladder pathology. Ultrasound is really the first step for evaluation. What else? There's so much.
Well, obviously the aorta, descending aorta. I mean, we already,
yeah. Yeah, AAA for sure. Super fast, super easy. If they don't have a belly full of gas, right? If they're not big and bloated, I mean, it's like literally takes 3 minutes, and you immediately can feel confident about their aorta, which is amazing. Down into the pelvis, obviously scan the bladder. Obviously all the pregnancy stuff. We do transvaginal ultrasounds for confirmation of pregnancy, looking for ovarian cysts, looking for ovarian torsion. Unfortunately, the numbers, the sensitivity and specificity for torsion is better for testicular torsion compared to ovarian. And so, you really can't rule out ovarian torsion with an ultrasound. I mean, you can try, but the sensitivity is down in kind of the 50, 60, 65% range, which is really not good enough for that, and that level of acuity of pathology. However, with testicular, it's super easy ultrasound to do. And I mean, you can check, and if you've got color flow on one side and you don't have color flow on the other side, you're done. That's it. It's a phone call to urology. Like, do not pass go. Do not collect $200. You're making that phone call. And so, I mean, it's just obviously DVT scans. I mean, it just goes on and on. I mean, you could just, I'm going to spend the rest of my life kind of like nitpicking into all the nuances of all the different areas. You get bored with MSK, you start, doing more lung ultrasound. You get bored with lung ultrasound, like you can start messing around with gallbladder, and you can just always get better. There's always more to learn, and we're always pushing the field.
That's great. Well, I hope that if you're if you're one of the community physicians like me, maybe you're JD's cohort, and you learned ultrasound from the first day of medical school. But maybe you're not, maybe not as old as me, but a community guy who's been out there practicing for a long time, and maybe the ultrasound skills have not really been honed in your practice. I would encourage you to just sort of start thinking about this and incorporating it in the next several podcasts, and we're going to salt them through EP Monthly, EP Talk. JD's going to go through a lot of different ultrasounds, and he's going to talk about technique. How did he, not only will you just see the result, which is inspiring, but you'll also see some of the techniques, and we'll talk about how he got those images. And I think that you'll find it instructive, at least entertaining, and maybe inspire you to add this skill, the depth of this skill, to your armamentarium of skills. And I think the whole field of emergency medicine will profit from that. It's where we're going as a group of clinicians. So I hope you've enjoyed this discussion, and I hope you'll listen to us. We've got another podcast coming after this. JD's going to talk about some techniques, and come back and watch EP Talk. Thanks for joining us.
Bye for now.